So thank you. Great to be part of this meeting and part of this panel. I'm going to keep my comments relatively short today and simple, although probably not at an 8th grade level. And mostly because the points have been made. I only have a couple of simple points I want to make that hopefully will generate a little bit of conversation about this topic. So whenever I talk with our medical students about informed consent, I like to start with this slide that gives us a little bit of perspective. And I'm going to be criticizing our profession a fair amount about where we are in this development. But this point sort of suggests that we've actually come a long way. So the obedience of a patient to the prescriptions of a physician should be prompt and implicit. He should never permit his own crude opinions as to their fitness to influence his attention to them. So 1847, so we have come a long way since then. So as we've heard through the day today, longstanding recognition that the consent forms in research, and I'm going to emphasize too this distinction between forms and process, first of all, are not evidence-based. In fact, the entire enterprise, for the most part, wasn't evidence-based when it was first instilled within the regulations. It was folks who, of good faith and good heart and wise individuals who decided what it is that people ought to be told in this particular domain. And so we have an opportunity now through the kind of research of folks on this panel and in this room to help guide this process more on an evidence base. Written at an educational level, it's too high for most participants, commonly use technical terms that are not understood by most participants, and too long with formatting that is too dense. So all the sorts of things that are quite familiar to all of us, and I assume folks don't need any additional convincing that that's an issue. So the process. Longstanding recognition that the process has a couple of challenges as well. It also is not evidence-based as it's currently conducted. Does not ascertain whether participants understand key information elements before a decision is made, can be insensitive to the stressful circumstances in healthcare environments. Not be conducive to a person with appropriate, may not be conducted by a person with appropriate skills, time, and expertise. Limited time for decision-making, limited opportunities for asking questions, and may not be adequately reviewed by the IRB. Now, I will say our IRB, and I think most across the country, are doing a better job with this in recent years. Used to be just the form that IRBs would attend to for the most part. Sometimes a great irritation to sponsors and investigators, but the form was the focus. Now, at least, there's a series of questions I think that most IRBs are entertaining about how does the process work. And as I'll probably say a little bit more, I'm not sure IRBs do a good enough job sort of exploring that process, but at least the investigators have to say who it is that's going to be obtaining consent, what's the environment, is it a staged process, et cetera. So you are doing a better job. And I should say in this regard, before I go too much further with the critique, that I do think the oncology folks have done a substantially better job than our other colleagues in this particular domain. In fact, that might be an interesting study in and of itself as to why the oncology field has been more proactive in this domain. Perhaps straightforward, the disease can kill you. Sometimes the treatments can kill you. And I think the role of advocacy organizations probably has been key as well. I think the oncology field probably has more effective patient advocate groups than many other areas of medicine. Anyway, it'd be interesting to sort of think about why it is that oncology has done better. At least within our institution, we like to, the oncology groups have done a wonderful job in being at the vanguard of some improvements, although, of course, much more to be done. So why have these challenges persisted? And this is really the simple point I'm going to make today. I think the alignment of incentives favors the current approach. And I think we're not going to get things fixed until we see a change in the alignment of the incentives. So I'm going to just sort of tick through a variety of what I perceive to be the incentives in this particular domain. So the sponsors themselves, whether they're commercial or not, they seek to relay comprehensive information about the procedures, the risks, and the benefits. People want to be comprehensive here. And you'll see a little bit further down the list is this notion of liability, but I actually don't think that's necessarily the predominant force. I think folks understand that this is a significant decision, want to make sure that the information is out there for folks to use. They seek to be accurate with the use of technical language. Technical terms have a purpose. It's very difficult to paraphrase technical terms in ways that can be accurate And so accuracy often demands that we use the technical terms that aren't accessible by many folks. Seek to reduce legal liability for inadequate disclosure. I think that is an element. My perception certainly is that this is not a rich or robust area for legal liability. Of course, cases out there, but for the most part, this is not a common source of litigation. Nevertheless, folks are always concerned about that possibility. Lack of comprehension does not appear to reduce recruitment. So here, I think, is a pretty significant factor. We're doing a lousy job, but it doesn't seem to matter in terms of getting people into research studies. I'm going to talk about that a little bit, or at least mention that when I talk about some of the incentives from the research participant side. But that's such an interesting phenomenon that folks aren't saying, you know, I'm not signing up for this unless I really understand what I'm getting into. For whatever reason, that's not part of the dynamic. And long, complex forms are acceptable to IRBs. IRBs approve these things. So why wouldn't the sponsors proceed with using them? So how about the investigators? And here I think the investigators mirror, from my perspective, a lot of those same incentives that sponsors have. They seek to be comprehensive with the information. Important decision, you ought to know as much as I can tell you before you make this important decision. And I also think there is some literature out there that I've seen, this perhaps coming out of the children's oncology group and Rick Kodish's work, that some parents really do use the forms as sort of an owner's manual to the study. And this is probably particularly relevant to the oncology field, where you have these studies that involve different stages over a period of time, and it may well be that parents want to say, okay, we're at the 6th visit, what's happening now? So this may be more relevant in terms of complex protocols common to oncology than other fields of research. Again, folks want to be accurate with the use of technical language. We spend a lot of years trying to gain facility with that technical language, so it becomes easier to use. Longer and more complex is easier to write than shorter and simpler. Reminded of the quote about the letter would have been shorter if I'd had more time to write it. Mark Twain, I think, attributed to him. Lack of comprehension does not reduce recruitment. Again, liability protections are still there, and again, it's acceptable to IRBs to be to approach the form and process in this manner. So, how about IRBs? What are the incentives on that group? Well, no regulatory requirement that forms be shorter and simpler. No regulatory requirement that participants understand key information. They too seek to be comprehensive and seek to be technically accurate, and there's lots of pressures within the institution to drop in legal boilerplate. And this occurs particularly with the injury compensation sections, I think, and of course, as we've heard with the HIPAA language, oftentimes is not written by so much the folks on the IRB as folks from the General Counsel's office. Pushing back against complex forms entails a conflict with investigators and sponsors. And as I joined my IRB 15 years or so ago now, you know, this was going to be an interest of mine in trying to improve this process. Well, it was quite clear early on that I was swimming upstream, and for the most part, swimming upstream alone. And this would involve a significant conflict with investigators and sponsors to try to significantly change this process. And I think the sub-bullet there suggests that as we move increasingly to multi-center trials, it becomes quite problematic for any one institution to try to take a lead on this and say, we're going to do a better job, because that may entail difficulties with uniformity across the study sites. And lastly here, helping investigators with shorter, simpler forms requires expertise and additional work. Writing in a simple fashion is hard, and it requires people who have some sort of special training. So simply barking at investigators to do a better job is not an easy, is not an effective solution, I should say, and that institutions ought to have people who can help individuals write in a more appropriate way in this context. Well, how about research participants themselves, or potential participants as people are thinking about this enterprise? And this is mostly supposition on my part, but interested, of course, in fostering some dialogue here. really rely on the trust of the investigators, clinicians, and the healthcare institutions to make decisions about participation. I think the literature is pretty consistent. The trust is a central ingredient to people's decisions to participate in research. And whatever's on the form, whatever's said as part of that conversation is not exactly secondary, but without that trust element, it's hard to get folks to participate. And so if they have that core element of trust, is that enough as far as they're concerned, as far as at least many people are concerned? The whole therapeutic misconception is one of the most challenging and problematic areas in this whole domain. And I've not seen good approaches to tackling what I think is a deeply ingrained psychological bias on the part of folks who are sick in particular. And this enhances trust. The whole notion is that I'm getting what I'm getting in the research protocol because that's what my doctors think is best for me as an individual. So undermining that notion of therapeutic misconception may in fact undermine some element of trust that's part of that relationship. People are embarrassed at revealing a lack of comprehension or potentially even a lack of ability to read. Concerns about angering or disappointing clinicians by asking questions or declining participation. How do you set up a process in which folks don't think that there's going to be some sort of subtle retribution for them if they don't participate? And subtle retribution in a context of oncology, perhaps, where you're fighting for your life, it can be a powerful motivating factor. Now, I've listed all these problems, and I think part of the implication of what I want to say here is that this isn't simply a matter of, doctors are a bunch of blockheads, why don't they get it? Because I think this is a fundamentally challenging set of problems. And the reason it hasn't gotten better is because it's an extremely difficult domain. We have a poorly educated public, really with very little or no research experience in most circumstances. Limited time is a huge element in almost any healthcare environment. There's a basic power relationship between institutions and people and doctors and people and investigators and people that is an integral part of that challenge. I think we haven't adequately taken account of the whole psychological domain that encourages passivity and dependence on the part of patients and people considering research participation that's born out of their fear and anxiety. So much of bioethics was founded on the notion of autonomy and that you give people information, they make logical decisions in their own interests. And that, of course, is such a shallow, inaccurate description of how people live their lives, particularly in the context of serious illness. The whole notion of autonomy has taken a bit of a step down, but it's still part of the pantheon of values that we want to promote here. But again, perhaps less insufficient attention to the fear and anxiety domain of the healthcare environment. And a strong desire to trust. We want people to trust. They want to trust. They want to be in a trusting relationship when they're threatened in these contexts. And this last bullet point, I think, is an important one. I don't think it's contrary to much of what we've heard with the panel today, but the research has, to my point of view, and I'd love to be found wrong here, has not demonstrated dramatic improvements through new approaches. I think some of the teach back and teach to goal has shown some significant improvement in those particular areas, but it's been an uphill battle. In other words, there's not an easy fix here where folks have said, if you write at an 8th grade level, folks are going to get it, right? It's not that simple, and we have to look at the entire complexity of the process and the psychology of the relationship. So here are a couple of assumptions that I'm making as I go forward with the next couple slides. I think we know enough to improve the forms in the process, but that's sort of an open question. There's been excellent research in this domain, but not enough. Has there been enough to say we know what we're doing in order to try to leverage some changes in the process at this point or not? Or would that be premature? Should we wait another 5 years and foster more research before we try to change things at a regulatory level? So I think that's an open question, but at least my assumption is we do know enough now to make some significant improvements. New ideas and data will not change the incentives. I think we can put lots of good templates out there, lots of good ideas, publish stuff in literature that says, here's how you can do a better job. But unless those incentives change, it's not going to help, right? I think the incentives are too strong in this domain in favor of complexity that I'm skeptical that fundamental change will happen without changing those incentives. Significant progress will only be made if incentives change. Just made that point. New regulations or guidance from DHHS is essential to change incentives. That's where the incentives are going to be. I think, from my view of the world, it's the IRBs that are going to change this, and it's the IRBs going to change it if there's guidance coming out of OHRP that tells IRBs you need to change this. So that, I think, is the leverage I'm looking to from my view of the world. So this goes back just a step to say SACHRP, and this is the Secretary's Advisory Committee on Human Research Protections that I currently chair. Barbara Beer, who will be speaking, I think, tomorrow, is the most recent chair. Stephen Jaffe has been a member of that committee. It's a committee basically that makes recommendations to the Secretary of Health and Human Services about human subject protection issues. OHRP provides our support and staff, and those recommendations are always thoughtful. Sometimes they lead to action. Sometimes they disappear in the black hole of DHHS. So, you know, what we say is only a set of recommendations that then has to go through the rest of the federal process. So one of the things SACHRP did do, and I would say that it's public process, so all of the recommendations we made are up on the website, whether or not they've been approved or processed by the Secretary. One of the things that's been done so far is to actually make some specific recommendations on the elements of informed consent to try to reduce those to a more manageable or flexible number. So folks are probably familiar with the current required elements, 8 of those, and then several optional elements. So the recommendations from SACHRP are really to have the required elements down to 5, the core things that every consent process and form ought to have, and then a longer list of optional elements so that you can really design your consent form and process around your particular study. Trying to give IRBs a little bit more flexibility in this domain as a way of simplifying and pulling out language that's confusing and not relevant to particular studies. So that already has been done by SACHRP, and I think is helpful for the conversation that we're having this morning. The bigger challenge is this: is there regulatory language to support guidance? Now, OHRP likes to have a regulatory hook in order to have something to say. No, they can't just make stuff up and say, here's what you have to do. That has to be pinned to the regulations to a certain extent. So, as we've heard already, the Common Rule 45 CFR 46 does say the information that's given to the subject or the representative shall be in a language understandable to the subject or the representative. So part of the question is going to be, okay, how much can we stretch this language? How much weight can we hang on this? You know, clearly it means if your participant is Spanish speaking, you need to speak to them in Spanish. Michael suggested that the interpretation also has indicated, well, you ought to be talking to them at a grade level that's reasonable for what their personal background would support. So a little unclear to me whether this is enough language to leverage things like teachback to actually figure out whether people understand what it is that you've just said to them. You know, since I'd like to get something done in this domain, my preference would be to hope that we can hang as much weight on this as possible, but that remains to be seen. And this contrasts with the World Medical Association Declaration of Helsinki, which is more explicit. Subject must be adequately informed, and then states, after ensuring that the subject has understood the information. Well, we don't have that as part of our regulatory landscape, but that's exactly the kind of language that we would love to have in order to try to leverage some of the changes that we're talking about. So my hope is to encourage a SACHRP initiative in this particular domain. We have had support from OHRP and from the Assistant Secretary of Health for making a concerted effort in this domain of consent forms and process. The ANPRM at least opened the door to potential changes in regulations. Been part of SACHRP for a number of years, and used to be in the past, folks would say, you know, changing regulations, that takes 7 years, forget it. Well, 7 years sounded like an exaggeration to me. More recently, it sounds like an underestimate of what it may actually take. So, but at least that process is going on now. I don't know any more than anybody else about what might be in there, but there may well be some changes in the informed consent form and process that come forward as part of that. Anyway, the fact that folks are at least willing to think about regulatory changes is a good thing. OHRP guidance may be appropriate route to leverage changes in IRB standards for informed consent. So guidance here, and IRBs take guidance very seriously, and often they're so afraid of negative findings by OHRP that if you put it in guidance, for the most part, institutions pay close attention to that. So we'll see this next month. I'm hoping the SACHRP will adopt a formal initiative to prepare recommendations to enhance the efficacy of the informed consent process would be the initiative. Okay, this is not the District of Columbia. That is, that's Utah. Okay, thank you.